Good morning.
Good morning.
How are you?
All right, and yourself?
Chocolate, because I pressed the wrong button.
Uh-oh.
I know. I was like, wait a minute, why are we repeating what we just saw? No, that was not the jam. How was your week?
It was okay. How about yours?
Good. I like the new coding nurse banner thing
Oh,
behind you.
thank you. And
Yeah.
I'm trying something different. I'm streaming to Instagram
I
live.
saw that. I saw that as well.
So
Now,
go ahead.
go ahead. We do that all the time. Only thing I don't know what to do with it afterwards. It gives some instruction to do something with it afterwards, but I've never done anything else with them afterwards. So
So I'm going to see how it works because right now there's like a 10-second delay on Instagram versus, through StreamYard. So I had to mute it on Instagram so I don't get
hmm
so I'm hoping that people can hear when they click in.
okay.
So we'll see, because I need to engage with this audience more, and it's
I,
starting to grow. So why not? Let's see what happens.
why not? Let's see what happens. I love it. I love it. Come on in, Instagram. Come on in. Come on in. Come on in. So how was you said the week was okay?
Yeah,
Everything. All right.
it
Our little
was it was a week.
it was a week. It was a week. Our little package arrived safely, or I guess packages arrived safely yesterday. So
Good.
I'm a little sleepy. I'm a little sleepy. Um, yeah, yeah. So what was I gonna say? I was gonna say something. Just life been lifing and things been things thinking and folks are all over the place and yeah. It was interesting yesterday with the blackout, as some folks call it, um, and hearing the "oh, I didn't know" or "oh, really? Well, I still got to do this," and what we got, and I'm like, "Well, y'all wouldn't have made it back in the '60s. Y'all wouldn't."
No,
I don't understand, but okay. Everything wasn't meant for me to understand, right?
facts. But I really like our topic to this
It was
morning.
I felt like it was a love letter when I reached out to her and was like, "Thank you so much for putting this together." It was so nice. I really like it. So I'm excited. Okay, well, let's get this party started. Welcome everybody to our Saturday morning tea. Here we brew up the hottest topics in healthcare. We discuss health information, news, education, certification tips, and entrepreneurship. You know, and what's been going on all week long and, and how life has been life in all of the things and really the revenue cycle at large. So as you come in, don't forget to hit the thumbs up or like button or whatever engagement tools and buttons you have in whatever platform it is that you're watching this on. I'm Clarice Warner. I'm the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network LLC, where coding education is key. So why are you typing?
Oh,
I'm like, all I hear is clickety clack. PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance in education. Now, let me ask you, do you know what it takes to be a certified marketable medical coder? Do you? Well, before I introduce my co host, who is working and typing away, let me share with you information on a free, free email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. Hey, all right. If you're interested and getting more information about the 5 steps to become a certified marketable medical coder, check the video description for the link. So again, joining me today is my partner in success, my co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I have been in healthcare for a very long time as a nurse. In 2014, I left the bedside and I transitioned into HIM as a risk adjustment medical coder. And during the pandemic in 2020, I created a company, the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
And how is that going?
It's coming along.
Yes. Love it. Love it. All
Yeah.
right. All right. Well, before we jump in, let me remind you that you can join in and add to the conversation. So don't be shy. Your opinion matters and is welcomed here. So, friends, use the chat. The only thing that we ask is if you have a question for us, that you put a Q first so that we know it's a question that you want us to reply to and you're not talking amongst yourselves and we don't miss it. So for those who are joining us or watching the replay, today we are talking medical coding, the unsung heroes of healthcare, and really just peeking into the clinical art of medical coding.
Yes.
Yes, yes. Okay, but first, our church announcements. Yes. Everybody got to get set up.
Yeah, you hear me, don't you?
Hey. Hey. All right. I'm gonna go to church and be like, y'all know this song? Play my church announcement song.
Look, in G.
Yes, absolutely. All right. So my church announcements, actually, I went out and I was trying to double check and make sure there aren't any work plan issues. You know, it's a new month and oftentimes they drop work plan. But then I thought, okay, wait a minute. There's a whole bunch of stuff going on in DC. So who knows if we're going to get any new work plan items.
That's true.
For the month of March. But what I did find is that HHS is about to do away with where did it go? It's about to do away with its public comments. And I said, well, what? Who does that? Where they do that at? For those who don't know, oftentimes when there's a policy or there's anything that's coming out of a policy change or revision, or they're adding something, and I don't think it's limited to just Health and Human Services. I actually think it's for any government agency, but specifically, HHS plans to revoke a policy on Monday, March 3rd, that requires public notice and comment. So they don't have to tell you nothing, and you won't get an opportunity to respond.
Wow.
And it says that this is for certain management areas. And so it says this move would repeal the Richardson waiver, which was established in 1971, effective immediately. The waiver required HHS to follow public notice and comment on procedures relating to public loans, grants, property, contracts, and benefits. And that was according to a policy statement from HHS Secretary Robert F. Kennedy Jr. Says in most cases, HHS agencies typically invite public comment for a period of 60 days before a final decision is made on a proposed rule. And actually, that has become standard, best practice, I guess, if you will, for a lot of places. The change would then realign HHS's regulatory processes more closely with the Administrative Procedure Act in what Mr. Kennedy said is an effort to streamline efficiency. HHS would also be able to forego public notice and comment periods for, quote, good cause, end quote, if it finds the procedures to be, quote, impracticable, unnecessary, or contrary to the public interest, end quote. The extra statutory obligations of the Richardson waiver impose costs on the department and the public, are contrary to the efficient operation of the department, and impede the department's flexibility to adapt quickly to legal and policy mandates, Mr. Kennedy said. Again, the policy statement is scheduled to be published in the Federal Register on Monday. I was like, wow, because it has been my experience, especially when reviewing like the inpatient prospective payment systems, the outpatient prospective payment system, the physician fee schedule, all of those things, when they give the I lost the word for it. They give the preliminary, and I know that's not the right word, but they give a preliminary notice, and so they let you know these are proposed. There we go. These are the proposed notices of what is coming down the pipeline, and allow people to put their eyes on it and comment to say, wait a minute, if you notice that this, that, and third, sometimes in the coding book, the way, they're trying to explain something or realign something or change something doesn't jive. And so this provides an opportunity for people to add to that and make, to bring that to others' attention so they can make the correct thing. Now, oftentimes there will be times where, government already felt the way they felt, and they were like, we appreciate all your comments, but we're moving forward this way. And then they let you know all of the things in the final ruling. But it was always also refreshing because you got to see all of the comments. They published all of that. So that you knew, who made comments, who and what was the impact on those particular comments. Sometimes they were very impactful, and it would lead to even further modification, or maybe even a pause. Like, well, wait a minute, let's take a pause and go back and look at this again to make sure that what we are proposing is in line with what we should be proposing. So I just thought this was real interesting.
I just think that moving forward, I think the word of the year is going to be disclosure, because that's what we're really missing out on, or what, as a Monday, because if you don't know what people are doing, how can you have any kind of dissension? How can you let your voice be heard? So
Absolutely.
it's going to be interesting to see how it plays out, especially when it
Absolutely.
comes to this revenue cycle.
Absolutely. We about to have a ride, y'all. Get ready. Buckle up, buttercup, as they say. Mr. Jesse, did you have any? That was the only one I had.
The only church announcement I have is I have a new ICD 10 CM class starting on Thursday, March 20th at 6 p.m. Eastern Standard Time. To find out more information, visit thecodingnurse.com.
Yes. Look at that. That was so nice. It's sweet and to the point. It was great. I love it. All right, all right. Let's see what we got going on. Good morning, Vicki. Good morning. Welcome, welcome. Good morning to our on the street correspondent, the crafty coder. Good morning. Good morning. All right, all right. So let the tea spilling begin. Oh, did you listen to all of the town hall stuff?
Actually, no.
Okay.
But as soon as I got the email, you were the first person I thought of. I said, I've got to see if she got it. And I'm glad I reached out because. So did you eventually get it, or
I
you
didn't
never?
see it. I'm like, what's
Wow.
happening? Am I banned? Do I have a letter on me? Even though I get all my stuff for the committees and such that the task force that I sit on. So I'm like, okay, we good. But yeah, unless it got buried somewhere, which is possible because it's been a week this week. When I tell you it's been a week, it's been a week. I'm like, well, what is this? Well, what is that? Well, what? I'm like, ooh, yeah. And that doesn't even include the students. It's been a week. All right. So today we're diving into a topic that's probably close to all of our hearts, but we're talking about the clinical expertise that makes medical coders true healthcare professionals. When people think about healthcare professionals, they usually think about, of course, doctors and nurses. That's who you normally see when you think, "Good morning, KK. Welcome, welcome." When in the healthcare arena, that's who you normally see, and so that's mostly primarily what folks think about. But there's an entire clinical team working behind the scenes, medical coders, whose
Yeah.
expertise in anatomy, pathophysiology, and pharmacology ensures the healthcare system functions. And today, we're going to shine a spotlight on these unsung clinical heroes. And of course, Mr. Jesse, you jump in whenever. I recently came across an excellent article by Amber Owens titled Medical Coders Are the Clinical Professionals Behind the Scenes. And so it inspired me. We were going to talk about it last week, but we had hot topic last week, so I held it for this week. And so I just wanted to dedicate today's episode to exploring why coding is far more than just an administrative function. And so I think most of us understand that, but some of us, even if you are a coder, may not understand really what your role entails and why it is so important. So grab your tea and let's celebrate the clinical professionals behind the scenes. The first, let's look at the clinical foundation of medical coding. And we can start by addressing, again, a common misconception. So, how many times have you heard someone refer to coding as those people over there that just handle the paperwork, or those people over there who just are data entry and putting in some codes? um, yeah, that you oftentimes hear that from people who don't necessarily know, or you tell somebody what your profession is or what your role is, and they look like, what did you, like, you just spoke a whole foreign language. What did you say? What do you do? Well, the reality is that medical coding requires an intricate understanding of clinical concepts that rival the knowledge base of many frontline healthcare providers. So, as Amber pointed out in her article, and the article is linked in the description, coders aren't merely processing data, they're analyzing and interpreting clinical documentation to ensure accurate representation of the patient's condition and the care provided. Again, this is kind of what separates some of these other administrative functions from what it is that we as medical coders do. Think about the depth of knowledge you need to do your job effectively. You're not just matching words to codes. At least you shouldn't be. At least you shouldn't have that mindset that is all that it is that you're doing. You're applying expertise in medical terminology that spans every specialty. In pathophysiology, where you're understanding how diseases develop and progress. In pharmacology, knowing medication purposes and their effects. In anatomy, mapping the human body in detail. And also surgical techniques and instrumentation, healthcare law and compliance requirements, and post-implementation.
Well, you started to sound a little muffled.
Did I?
Okay, it's better now. Yeah.
Uh-oh. Am I back?
Yes.
Okay. I probably walked or moved away from the mic. Also in health information systems. And then also, depending on specifically what it is that you're doing, complex reimbursement methodology. Can you hear me? Well, it's better now. Okay. All right. Let me give you a real world example. When a patient chart mentions diabetes, you can jump right in. A non-clinical person might think, okay, there's a diabetes code for that. Let me find you that code. But as you as a clinical coding professional immediately start
Scoot a
analyzing.
little closer, because now I, or maybe put your hands out. I don't know, something that is blocking something.
I'm blocking.
Yeah. Okay. All right.
I'm laughing at Vicky's at her comment. Even though I love peanuts and Snoopy and all of the things.
Okay.
Okay.
Yeah, it's fine. Yeah.
Is that better?
Yes.
Okay. Do I need to go back? No.
No.
When, as a clinical coding professional, immediately you start analyzing, is this type 1 or type 2? Is this a new diagnosis or is it established? What complications are documented? Is there nephropathy, retinopathy, neuropathy? What are the other things that we see? Is there documented causal relationship between the diabetes and these conditions? And then also, are there medication details that provide additional context? Or consider this scenario: a patient is on metformin. A non-clinical person might just see a medication name, but you understand this likely indicates type 2 diabetes, and you know to look for documentation supporting that diagnosis. You understand the mechanisms of action for different medications and how they relate to specific conditions. So, again, this isn't administrative work, this is clinical analysis at its finest. Mr. Jesse, you want to jump in there?
Yeah, because I think that there's just an entire misconception with the medical coding profession, period. Like I so many people think that it is just looking up codes in a book. And it is so much more than that. It's so much more detailed, and there's so much more you need to know. And a lot of people don't also know that according to the guidelines in ICD-10, CM, and PCS, the provider does not have to write out certain things the way we would want it to be written out. We
Yeah,
also know that there are assumed causal relationships based off of the guidelines. So if it's documented in a certain way, that is enough for us to apply combination codes, or for us to assume that there's a relationship that would cause the situation to be coded differently. And that's way above what a provider should have to do. All they have to do is document the conditions, and it's up to us with our coding knowledge to put it together to paint an accurate clinical picture.
absolutely. Absolutely. And again, this level of clinical knowledge isn't optional for coding, it's fundamental. Without it, the entire healthcare system would collapse under inaccurate data, compliance issues, and financial chaos. Hmm. Hmm. It's like it's just data entry. Excuse me. Right, right. So the nurse and coder connection.
Uh-oh.
Buckle up. Just that the one of the most interesting points in Amber's article is the parallel she draws between the knowledge base of nurses and medical coders. While these roles appear different on the surface, the underlying clinical foundation is remarkably similar. Think about it. Nurses assess patient symptoms to provide care, while coders analyze those same symptoms and corresponding treatment plans to assign codes that accurately reflect the clinical scenario. Both require a deep understanding of how the body works, how diseases manifest, and how treatments affect outcomes. Both nursing and coding demand fluency in medical terminology, whether documenting care at the bedside or translating that documentation into codes. This shared clinical language is critical for accuracy and patient safety. Nurses follow clinical protocols to provide standardized evidence based care. Similarly, coders follow official coding guidelines for ICD 10-CM, CPT, PCS, and HCPCS to ensure standardized compliant coding. Both sets of guidelines require interpretation and application of clinical judgment. They're not simple checklists. Let me also share a quick story. A few years ago, I actually was auditing charts at a hospital where a patient had been admitted with what was initially documented as simple pneumonia. A newer coder had assigned the basic pneumonia code and moved on. But an experienced coder recognized clinical indicators in the documentation, the specific antibiotic therapy, the isolation precautions, and certain lab values that suggested that this might actually be a more severe form of pneumonia. So this coder collaborated with the CDI specialist to query the physician who confirmed it was actually MRSA pneumonia, a much more severe condition that different treatment protocols and resource that would require different protocols and resource requirements. Coder recognized clinical indicators. Sorry. I was like, hey, I'm talking. I hear me. This wasn't just a coding change. It was a clinical clarification that impacted the patient's care plan and the hospital's quality metrics. That's the level of clinical thinking coders bring to healthcare every day. It's not just about selecting codes, it's about ensuring the clinical story is accurately captured and translated. And so, in many ways, coders serve as clinical validators. There is a job description or a job title that says clinical validator, using their expertise to ensure that what happened at the bedside is accurately reflected in the patient's record. And again, this isn't administrative work, it's clinical documentation integrity at its finest. Also, from a personal experience, when going through, especially if you're coming in through entry level medical coding or health information, and I'll say health information program, but actually both, you're required to have those courses that nurses have. And so you're sitting in the same room getting the same education that nurses would get. Again, your focus and plan is a little different. Again, they're getting the knowledge and information to assess and provide the bedside services they need, and we're getting it to be able to analyze the information, but you're still getting the same education. Mr. Jesse, did you want to jump in and have something to say regarding that?
I totally agree. It's just it's a collaboration, and maybe that could be what is missing, because in nursing school you're always taught, like they start from day one, that it's healthcare is a team approach, and they used to have a model called team nursing
Mm-hmm.
before they went to the primary nursing model.
Mm-hmm.
So you know nurses are taught from the beginning that it takes a village to take care of a patient. And I don't think that really gets um, stressed enough in HIM programs. And I don't think that there's enough, because we all know, like in hospitals, like coders are off in these rooms that nobody knows how to get to but them. A lot of times they were like off the out of the way places. So, you're all there. It's almost like it's an invisible team somewhere, but they really are still part of the team. And I think that because like nurses see other departments, like, that come to the floor on a regular. And it used to be, before things went more remote than what they are, even CDI used to come to the floor. So they would see them,
Mm.
but not necessarily coders. And I think that really needs to be stressed, that it is a team approach for
Mm.
everything in healthcare.
Mhm. Absolutely. And in the revenue cycle as well, because we all rely on someone or something upstream, and then what we do impacts downstream. So understanding that um, could possibly make a huge difference in some of our outcomes. So now some of you might be thinking, but I never interact directly with patients. So how am I affecting patient care? Well, let's talk about the very real ways coding expertise impacts patient outcomes, even without that face to face interaction. So, first, accurate coding ensures that the medical record correctly reflects the patient's condition and the care they receive. This isn't just about the current encounter, it affects all future care decisions as well. So, when a provider pulls up a patient's history and sees codes for specific conditions, complications, or procedures, those codes inform their clinical decision making. Inaccurate coding can lead to inappropriate treatment plans or missed critical context. So consider chronic conditions like diabetes with complications. If those complications aren't properly coded, they may not appear prominently in the patient's history, potentially leading to missed opportunities for intervention in future encounters. And then, secondly, coding directly affects healthcare quality metrics. You're capturing the data that feeds into hospital quality scores, infection rates, readmission statistics, and outcomes reporting. These metrics don't just live in administrative reports, they drive quality improvement initiatives that directly impact patient safety and care protocols. So for example, when you accurately capture hospital acquired conditions versus present on admission conditions, you're providing critical data that helps facilities identify and address patient safety issues. Your coding helps hospitals recognize patterns and implement preventive measures. And then, third, let's talk about the financial reality. Without accurate coding, healthcare providers wouldn't receive proper reimbursement for services rendered. This isn't just about profit, it's about sustainability. Facilities need resources to continue delivering high quality care. So, and to also invest in new technologies and maintain adequate staffing levels. Your coding ensures that they have the financial foundation to provide excellent patient care. And then finally, my love, compliance. Coders ensure adherence to regulations such as HIPAA, Medicare, and Medicaid guidelines. This compliance protects both patients and healthcare organizations from legal and financial repercussions that could ultimately impact care delivery. Remember this: every code you assign tells part of a patient's clinical story. Your work ensures that story is complete, accurate, and properly conveyed to everyone involved in that patient's care journey, now and in the future. Mr. Jesse.
Another thing that as you were talking, I was realizing that in outpatient, when you are coding, you don't really see the financial impact. Well, I'll back up and say what when I'm teaching my coding classes, I always tell my students that almost every code you assign is attached to a dollar sign in some way, shape, or form. The amount varies, and the type of code that you assign varies in terms of whether it is reimbursable or not. And in outpatient, when you're putting in codes, you don't really see the financial impact. But when you work inpatient, when you use the encoder, it tells you, like you see it. You see instantly when you put that condition in the first position, what kind of financial impact you're going to get, or if you put in that secondary diagnosis, you see how it either affects or doesn't affect the reimbursement that that hospital is going to receive for that care. And I think that that could be part of the problem too. I think that in outpatient, people need to see it, because I never really focused on reimbursement as much as when I did work in inpatient, because it's in your face, it's staring at you all day long.
Well, I mean, they have similar methodologies in order to come up with those particular dollar figures so that they understand what they are. Um, CPT has your RVUs that will assign each code a dollar figure to let you know,
Right.
these cases would could potentially, if documented accurately and coded correctly, get XYZ dollar amount.
Right. No, I'm not disputing that, but I'm just saying it's not visible to the coder when they're coding, like it is when you're inpatient. When you use the 3M encoder, it is right there on the screen.
They don't use 3M encoders on outpatient in facility?
I've not, even when I did outpatient, I didn't know. If because outpatient, if they use, I've used like Athena, eClinicalWorks, you don't see that.
Mm. I'm sure it's there, but to your point, it may not be visible right there when they're inputting the codes in the system.
Well, I mean, you can go to billing
Mm-hmm.
because they have tabs, but that's not the same as when you're actually putting in the code. Like it's instant, like you see it, it's right there.
Mm-hmm. Mm-hmm. And then we got professional development and future trends. So as we look to the future of medical coding, we need to recognize that the profession is evolving rapidly, very rapidly. The increasing complexity of modern healthcare demands even greater clinical insight from coders. Credentials like CPS and CCS and CCSP and specialty certifications aren't just letters after your name. They represent rigorous testing and validation of your clinical knowledge. Should be. These certifications require ongoing education in medical science and coding standards, similar to the continuing education requirements for nurses and other clinical staff. The emergence of value-based care models elevated the importance of accurate coding even further. In these models, reimbursement is tied directly to quality and outcomes, making your clinical expertise more valuable than ever. Again, you're not just capturing what was done, you're helping to demonstrate the value of the care that was provided. As we look ahead to ICD 11, the clinical demands on coders will increase even more. ICD 11 contains significantly more clinical detail and will require even deeper understanding of disease processes, relationships between conditions, and clinical concepts. Technology is also transforming the coding landscape. Computer assisted coding and AI tools aren't replacing coders, they're handling the straightforward coding scenarios so that you can focus your clinical expertise on the complex cases that require human judgment. The future belongs to coders who can combine technological literacy with deep clinical knowledge. To thrive in this evolving environment, I encourage you to continuously expand your clinical knowledge through targeted education, pursue advanced certifications in your areas of interest, develop relationships with clinical staff to better understand their documentation challenges, embrace technology as a tool that enhances rather than replaces your expertise, advocate for recognition of coding as a clinical profession within your organization. Mr. Jesse, did you want to jump in? Have some thoughts?
I agree with all that, and I just think that with these looming cuts to Medicare and Medicaid, which a lot of it just boggles my mind that a lot of people in this country really don't realize that the government is the largest insurer in the country. That is going to really affect a lot of. It's just going to affect everything in healthcare, and I think that it's going to also. I think people are going to delay treatment, which means that when they access healthcare, they're going to be even sicker, and there's going to be even more complex coding. So I just really think that you know it's just in everybody's best interest as a coder to really drill down on those guidelines and just know how to make sense of all the chaos that's
Mm-hmm.
potentially coming.
Mm-hmm. I don't know if I did this. She said TNC is speaking to coders as SMEs, subject matter experts. That's an excellent point. Outpatient CDI is still in development and needs to take it more serious. Tanika says, I see the dollar amount potential in 3M for surgeries. Good morning, Tanika. ICD 11 with, I think that's will be all digital, no books, and sequencing won't be as important based on how the code is going to be created.
I don't know
I
about
don't know about
that.
that.
Yeah.
I
I
don't know
don't,
about that. Not from the information I've received and actually gone out there and looked at it. It's going to be a digital model to assist with um, adding it seamlessly into like these encoders and those types of things. But I don't know that. Yeah, I,
That
that's
that may
you.
be, but that don't mean it's
That
law and gospel.
correct. We've had the people that are actually sitting on those task force have communication with us about that. And again, ICD-11 and what the United States usually does to ICD and whatever number is very different. And so depending on if and when, how that is going to turn out will be the actual final straw on what it will look like for us here in the U.S.
I just hope that there's a book. That's all. I really do want a book because I don't trust. Well, actually, I don't. I only use an encoder when I was working inpatient because I had to put in the codes. But did I use it to find codes? Absolutely not,
Mm.
because those because those programs are created by people who are not coders, so they don't know what information should be where. It's too cumbersome to find the information you need. I love being able to flip through the alphabetic index and then go to the tabular or go to the various indexes to find exactly what I need
And to
because it was
verify it, that's
right,
what we.
because it was designed for coders.
Mm-hmm.
These digital platforms are not designed for coders, and in my opinion, the reason why a lot of people like these digital books because they don't know how to use the code book to begin with. They don't know how to freaking code.
You
That's
better
their
tell it.
problem.
You better
That's
tell
the
it.
problem.
Wait a minute,
And
what you do?
you should have wherever you went to school should have taught you how to use a
How
coding
to
book.
use a
And if you
book.
don't know how to use a coding book, that's not the industry's problem. And the quick fix is not to, oh, we're going to go to a digital book. You still going to F it up.
Mm-hmm. Mm-hmm. And maybe that's some of the issues and problems that we have now that they are just using digital products to assign these codes, and then you're missing things. I don't, and yeah. Uh-oh. Look, I saw your nostrils flare.
Cause it's like they act like a digital book is like the second coming. No, it's not. And and these are people who have like I've seen Codify. It's not the same as a
Mm-mm,
book. It's not.
mm-mm, mm-mm. And well, you see, I'm about to get in trouble. But and I believe Codify is the AAPC's.
Hmm.
The AAPC books wasn't all they were supposed to be. So I would be nervous. I wouldn't use an AAPC coding
Nothing.
book. I yeah, in my experience, those were not my books of choice, and I did not have my students actually use those books either. But yeah, let's see what Vicky said. Maybe with ICD-11 there won't be books because it's so advanced and expanded. At least not a book we can carry. Uh, we used to lug around them books for years. These even the books we got now is nothing compared to the books we used to have and what they. And I don't know how far back you go, Mr. Jesse, but we had the books that stayed on the desk, and you didn't get a new quote unquote book every year. You got pages that you had to replace in your book. So it, things that were constant and stayed the same, you didn't have to worry about. But the new pages reflected any new guidance, any new codes, any new whatever. It was a whole party just to put those books together every year.
No, I don't go back. Now I go back that far in nursing school. I went to nursing school with Bunsen burners, but not coding.
Okay, okay. Oh, it was a thing. That it was a huge purple book that was like plastic covers, and they developed like these stands. Somebody created. Look, they made a lot of money off them stands. They had these stands that because that book was huge, and this was just your um ICD 9 back then book that you had, and this was before they were like, let's put these in some paperback form and let's start just giving books out every year, because it was a job, it was a task, to make sure that you had the pages in the right place and folks, yeah.
Look, Dr. Jasmine's co-signing.
Yes, yes. She said I can find it in a book. I get lost in a platform.
and
Absolutely. And we all know that I'm not a cloner, haven't been in years. Yes, you got pages in that Burgundy book. Ma'am, that was back in the day. I'm dating myself right now.
that's all right.
But you knew how to use that book. You knew how to add those pages. You knew what was in that book, all of the things. So yeah, I'm like you. I prefer, I use platforms for other things, but when it comes to my
Exactly.
down and dirty true coding, I need a book. I want
And, all right, we can move on. I ain't even going to belabor the point because even these people, even with DRGs, you used to have to use a book to assign a DRG.
Mm-hmm.
I used to teach my students they had to learn how to do it manually. Because
Mm-hmm.
what happens if it shuts down? You're gonna just, oh well, we can't do it. Well, yeah, that's what they'll say. But you should be able to still do it. There's a way. CMS puts out a whole
A whole
spreadsheet.
website, a
It's
whole
just
spreadsheet that you have to go through. And we're teaching our students to do the exact same thing. You have to be able to assign your MSDRGs, your APCs, all of those things. You need to know how to do that. Because to your point, stuff can shut down. And nowadays, stuff can really, really shut down.
because
And you need to know how to do that.
look at during the healthcare hacks that happened in late 23, early 24.
Mm-hmm.
You have whole health systems for months going back to paper notes.
Mm-hmm. Mm-hmm. And then folks looking like deer in the headlight, like, what is this? A paper
Exactly.
note? What am I supposed to do with this? Where? What? A
When
book?
I
What?
when I had to do that, when I had to go back to that, because we were where I worked was impacted for like 3 months, and
Absolutely.
when I
The work don't stop.
trying to read those handwritten notes again, and it was back to the whole thing. Can you look at this and what does it look like to
Yes,
you?
you pass it to like 3, 4
Yeah,
people.
yeah,
Do we all agree that this says the same thing? Okay, let's move forward. That's when the teamwork was involved, trying to decipher somebody's
yes,
handwriting. Like, Lord, sign your name that way. Don't write your notes that
yes,
way.
yes.
I used to stress that all the time. Please, just print. It's okay.
That's right.
It's all right. Oh my goodness.
It's just when it comes to the book, I'm like Linus on Snoopy. I need a book. I get so much comfort.
I do too. And I appreciate that that's still part of the education in coding. Um, not just for historical purposes, but for you to be able to understand, because showing people how to use the book and what conventions are in the book and all of those things allow them, in some cases, even if they're using the digital platforms, to start asking, well, where are these conventions over here that I need to know to be able to code XYZ? Oftentimes that part gets lost in, oh, well, the computer assisted coding prompt gave me da 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 da. Well, then can you reverse engineer that to find out what it was and if that's truly what it is that you need based on the documentation that you're looking at? And oftentimes folks cannot. So yeah, I agree. Team book, team book. Hi, Carolyn. All right. So as Amber Owens eloquently stated in her article, again, I just felt like it was just a true love letter to what we do in the medical coding profession. This is quote, recognizing medical coders as clinical professionals is not only accurate, but necessary to appreciate their invaluable contributions to healthcare, end quote. So you are much more than data processors. You are clinical professionals whose expertise ensures the integrity of healthcare documentation, compliance, and reimbursement. Your work supports the foundation of patient care, ensuring that the clinical story is accurately captured, reported, and acted upon. Let's see what she says. Miss Dr. Jasmine says, I have had employers talk about coders who would interview well but refuse to take the coding test for employment because they did not know how to use the book. Wow. Oh my God.
I can certainly believe that.
Oh my God. Be like, what's that? Because if they will slide them little books up, hopefully the books are current. That's another thing. Why people be holding on to old books thinking that that's what you're supposed to have for the current day work is beyond me. But yeah, we're gonna have to do a whole show on books.
That's true. Because
Oh, he said the actual privilege. Absolutely, absolutely. Mr. Jesse, did you have anything else to add?
no, I'm not getting on my soapbox. I've been on it enough today.
Yes, that is crazy. It's like books from 2020. You can't. What is that? What is that?
And that's what I like about AHEMA, because when you sit for any AHEMA exam, you have to have current year books.
Yeah,
Now, AAPC, well, you could either have current year or the year
before.
prior, but I
Hmm.
wouldn't. But
I
with all
wouldn't do
these
it.
changes,
I never advise that. I'd be like, I'm
no.
sorry. I know you probably started your education the year before and you bought those books to use it with that, but when you sit down for that exam, you need to be prepared. You need to, and that's preparation, having the current tool, because there's a possibility that you may miss something, because oftentimes when they're going in and updating their exams, they're updating it based on the new information that occurs from year to year.
And I had that happen. I had a student who was going to sit for the HCSD, for the home care diagnosis credential.
Hmm.
She waited because I try to tell people test as soon as possible, like at least
Hmm.
like 6 weeks. Set a timeline for 6 weeks and get it done.
Hmm.
She didn't. She waited until the next exam came out, and that particular year in October, they had changed all these dementia codes. And I mean, it was crazy the amount of changes they had for those dementia codes that year. And she said that she was like, I couldn't verify them because they weren't in a book. Well, the book changed
Mm, that's
and
horrible.
she didn't pass.
That's horrible. And that's why it's important to stay up to date on the changes that occur. We talk about that all the time. I tell y'all, hey, final rule. Well, I don't know what's going to look like now that the public comment and stuff is going away, but I'll tell y'all.
Oh, Dr. Jasmine
Yeah, we
added
got
it.
it. I don't know who didn't, but we understood. Look, we
Hmm.
understood the assignment. We understood
Right.
what you were saying. Because they're not going to slide you in front of a computer to be like, okay, well, go ahead and answer this uh, pre-employment test. They're not gonna do that oftentimes.
And then because then what happens, because like I had a travel position where my job would send me to offices to do reviews. All I had was a laptop that had the list of patients and the software for me to put in the codes. How you going to do that?
Hmm. Absolutely. How you gonna do that? I don't know. So as we wrap up today's episode, as we almost at the top of the hour, I want
Yep.
to ask you, our Saturday morning tea community, to think about your experiences and share your experiences in the chat. You don't have to necessarily do it now, but when you come back, put the information down there. Now, let me ask you some questions. How has your clinical knowledge impacted patient care? And do you understand that it does? What areas of clinical expertise do you feel need more recognition? What aspects of your medical coding role do you find most clinically challenging? How has your clinical knowledge base expanded since you began your coding career? Again, share an example where your coding expertise directly impacted patient care. Again, we need to start sharing these stories and sharing this information to show people what it is we do and our impact. What clinical knowledge area do you feel needs more attention in coder education? Hmm. How do you explain the clinical nature of your role to those outside the profession? What resources do you use to stay updated on clinical advancements in your specialty? In what ways could healthcare organizations better recognize the clinical expertise of coding? And finally, how do you see AI and technology affecting the clinical aspects of medical coding? So it's just some things to think about as you ponder on your role as a uh, clinical person. That we keep telling y'all been clinical all along in medical coding. So
And medical coding is STEM.
medical coding is STEM. Absolutely, absolutely. Nothing has changed in that. Even though, oh Lord, we got stuff going on with the Department of Education, but hopefully everything stays the same. We have been identified and characterized as a STEM profession. So um, you can scream that from the rooftops. Okay, what did you say? Better stay up to date because when the change from ICD 9 to ICD 10 happened, we had to do a competency test to keep certification. Absolutely, absolutely. And so many people, well, there were a lot of people who were adamant. I'm retiring. I'm checking out. I'm not doing all of that. They refused to do it. And yeah, that was interesting.
And I don't understand like what, because I learned the ICD 9 first. I
Hmm.
was on like the tail end of it.
Hmm.
And if you know the guidelines, the only thing that changed was the actual code at the end of it.
Specificity.
Exactly.
And
Oh,
looking
you
for the
just you
documentation
still
that
go
that
through it the same.
specified the code.
So,
Absolutely.
so that's why I mean I don't know for sure, but that's why I think that whenever 11 rolls around, there's going to be a book, and there's going to be guidelines. If you know the guidelines, the code system doesn't matter
Hmm.
because you have to follow. It's going to lead you to the right place if you're doing it correctly.
Hmm.
Doesn't matter whether it's 5 letters or 17.
Lord, please don't let it be 17. But I mean, and that was the other thing, one of the reasons why the transition, because at the time with ICD 9, we just had numeric values. They were running out of numbers, they were running out of spaces and placeholders. And so that's why they went to a alphanumeric system. But yeah, it's going to be interesting. It's going to be interesting. Well, that's what we had.
Oh, Doctor, I really want to touch on Dr. Jasmine's comment.
Let me get to what she said. Okay. I want more coders to get into data analytics. We just had this conversation last week. They
Can I,
can help with identifying service line and reimbursement twins or
Doc,
trends. Sorry.
Dr. Jasmine, you are speaking my language, but I'm telling you, the problem is, I don't know. Well, I'm just going to say it.
Say it.
Coders have become lazy. And if you can't take the time to go through the alphabetic index, find it, index it properly, and then go to the tabular to verify it, how the heck are you going to write a SQL script that's going to go through
Mm,
10, is going to go through 10,000 rows of data?
you better say it.
It's not going to, unless the work ethic improves, because coders would make amazing data analysts. But
Hmm.
there's I'm gonna say it, there's a spirit of laziness that's in the industry.
And reliance on your coded assistant on these tools. They think that's
Yes.
the end all be all. Oh, he gave me that. Well, that must be right. No. 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 Yes, Crafty Coder. I've seen you. The ICD 11 codes are already out. So yeah, I've
They've
seen
been
them.
out.
They've been out. I've talked about them for a couple of years now.
Yes.
Uh huh. Yeah, you can go out and check them out and play around with them and see how, because I believe there still are um, the various areas in ICD 11 that you have to go and validate to make sure that the code is correct.
I have a question from somebody on Instagram. It
Look
says,
at you following the Instagram people. Go ahead.
what are your thoughts on AI coming to health information management? So, medical coding building solutions, we talk about this a lot on the Saturday morning tea. And my thought is that AI is just a tool. It is not an end all be all because it will never have the level of accuracy as somebody who is rooted in guidelines and knows how to use a book or an encoder to really, really not only code it correctly, but also validate it. So it's going to be a tool, but I don't think it will ever replace it,
I
ever
don't
replace
either.
coding.
I don't either. And like I even said today, some of those frontline one-off easy codes, I guess, or services that are coded or diagnoses that are coded, um, using it as a tool to assist in those, but there still has to be validation. And so you will always have a human body validate the information that is coming out. Otherwise, you playing Russian roulette with your data, your reimbursement, and all of the things. And unfortunately, a lot of folks
Absolutely.
are taking those risks and doing just that. Vicky says, I'm still just learning coding, so it's not a career for me yet, but I can see being extremely detailed is very, very important. And yes, you have to know anatomy really good. Absolutely. You sure do.
Yes.
And it's that's one of the things that they would actually ask. Are you or would be in job description, detail oriented. You have to be able to follow the breadcrumbs. You have to follow all of those things in order to make sure and to validate and be able to reverse engineer things, especially if you're coming from like an audit perspective. Well, how did they get here? What did they see to even get here? And then show them, well, this is the way in which you should have went in order to get the accurate code that you were seeking. What you see?
Dr. J.
Ooh, I can answer. Oh my goodness. Oh, good.
Dr. Jasmine, I think we might have to have you back.
We have to have you back on the show.
Yes.
Just let me know. We'll definitely have you back.
But overall, I just want to say, like, the Saturday morning tea is just, it is two people that love HIM. I mean, I really, 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 really like it. I actually like it more than I like being a nurse, but I really appreciate my nursing knowledge because it has helped me tremendously in coding.
Mhm.
But I wish I had known about this 20 years ago. And it's just the HIM is broad enough that I believe that everybody can find their place in it. I
Absolutely.
really do. Because there's
Absolutely.
so many things you can do, so many avenues, and it's just a lot of people are just not aware of all that's available in the industry.
Yeah. And that's sad. And
It
that's
is.
one of the things that we do here is try to keep people informed. Um, and encouraged. Hey, and I remember, like you said, I knew about it 20 years ago, and I would tell people all the time, stop playing, come over here and get this money. This is a profession that, especially back then, there weren't a lot of people that looked like us in our profession. But we were coming out of school, and a lot of people were pushing folks into other healthcare careers, and then folks learned very quickly that wasn't for me, and then they just walked away from healthcare altogether. And I'm like, no, there's a whole business of healthcare that requires people's knowledge, skills, expertise. Come look at it, come try it out, come see. And then there's this specialty part in it that is medical coding, that is part of the health information profession, that take a look at. And I would try to tell people all the time, look at this. So it amazes me still to this day that people be like, well, what is it, well, what is that, or what?
And look at Dr. Jasmine's comment, and I have a comment from Instagram I want to read.
AI will not replace or displace as long as you take the initiative to learn about how the tools will improve the workflows. It goes back to transitioning from paper records to the EHR. We have to adjust and adapt and pivot and be ready and be prepared. And that's some of the things that people just don't want to do is the prep work for that. Go ahead, Mr. Jesse.
And I have a comment from Cute from Morning, and she says, I recently transitioned to risk adjustment coding from being an RN for the last 8 years. This has been my second year, and I want to give my respect to medical coders because it is a true art. It really, really is. And
Mm-hmm.
congratulations on your transition. And what you might want to do since you're going into your second year is sometime this year, set a goal and look into getting your CCDSO so you can move into CDI for outpatient.
Mm-hmm. Absolutely. Absolutely. All right. All right. This was a good topic.
Yeah,
Again, I felt like it was a love letter.
yeah.
I felt like it was a love letter. Let me find my a little thing. There we go. There we go. All right. Well, again, you can drop your thoughts in the comments and we can continue this important conversation and sharing the love on whatever platform it is that you're watching this on. So, are you thirsty for fresh perspectives on the healthcare revenue cycle? By becoming one of the PRNT sippers, you'll join a community of sharp minds who savor the complexities of the healthcare revenue cycle. Why sip alone when you can steep in knowledge together? Come, let's spill the tea on industry insights. And here's what you can expect as a valued member of the Tea Sippers: exclusive healthcare insights, gain access to in depth articles, webinars, and resources covering the latest healthcare trends, compliance updates, and revenue cycle best practices. Early access, be the first to receive expert insights and guides, ensuring you stay ahead in the ever evolving healthcare industry. Personalized support, enjoy direct access to our team of experts for guidance on medical coding, compliance issues, and revenue cycle management. We're here to answer your questions and support your professional growth. And then, of course, my personal favorite, community connection. Join a private community of healthcare professionals where you can network, share experiences, and collaborate on finding solutions to common challenges. So, by supporting us, you're not only advancing your healthcare knowledge and career, but also contributing to the success of the Professional Reimbursement Network LLC, a resource that empowers healthcare professionals like you to thrive in their roles, goals, and dreams. So, thank you for considering becoming a member of the PRNT Sippers. For the cost of what, 2 cups of tea per month, you can join the community. So check out the link in the description of the video. Your support means the world to us, and we look forward to helping you excel in the world of health information and healthcare revenue cycle. Yay! Well, thank you all again for joining the Saturday morning tea or checking out the replay. Let me ask, was the tea spilled today? Was the tea spilled today? Put your
Most
tea
definitely.
cups in the chat. Yes, look at Tanika already. Own it, own it. Hot tea for everyone. Thank you. You're welcome. You're welcome. Now, before we sign off, I've got a special request for you all amazing viewers out there. If you found this episode helpful, don't keep it to yourself. Share the knowledge with your colleagues by hitting the share button. And hey, why not subscribe to our channel while you're at it? That way, you'll never miss a drop of our health information, compliance, revenue cycle, and medical coding tea. We're here every week for you. Pop in and share the love. Got thoughts, questions, or experiences you want to share about today's topic? Well, we'd love to hear from you regarding that as well. So, as I mentioned before, keep the comments coming. And let's continue to talk about the love letter, if you will. And if you enjoyed this episode, give it a thumbs up. It helps more healthcare professionals find our content. Also, check out the Coding Nurse channel on YouTube and on Instagram. Is it the Coding Nurse? What is it on Instagram?
Yes, the
Okay. And the
coding nurse.
Coding Nurse
Yes.
on Instagram, since he's building that audience as well. Remember, at the Saturday Morning Tea, we're all about building a community of savvy, informed healthcare professionals. So, again, like, share, subscribe, and comment, and let's grow this community together. Mr. Jesse, do you have any closing thoughts for the people today?
My closing thought is same every week. I really appreciate you creating this platform, and I just wish that more people knew about HIM and would seriously consider it as a career. And I thank you for creating this space.
Oh, you're welcome. You're welcome. It's been a pleasure Like you said, we're just two passionate people about our profession in health information, and just want to share the love and knowledge. And I also want to personally thank those PRNT sippers who help support us in this endeavor every week as well. So this has been a great session today. I'll see you tea sippers at 10:50. Well, in about 5 minutes. Eastern Standard Time. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. Have a great weekend.
Bye bye.
Soon. Bye bye.